Okay, good evening. Thank you for coming, those who've come here and those who've joined online. So this evening, it's my privilege and honor to introduce Dr. Dan Munday, who will be speaking to us on his experiences from the work in Nepal in integration palliative care in non-communicable chronic disease management within the rural hospital and community settings. He is a GP by training from UK with special interest in palliative care. He spent more than a decade in Nepal developing palliative care at the primary level. He currently works as a consultant in the INF Green Pastures Hospital, Pokhara, Nepal. His passion is in developing primary palliative care to strengthen palliative care delivery by the primary care team and in the community setting so that it reaches people where they are at their home. He is an advisor to the Nepalese Association for Palliative Care, a senior advisor at the Global Health Academy, University of Edinburgh, and an associate editor of BMJ Supportive and Palliative Care. So he has spent time here in Vellore with us and helped with training, initiating training with our family medicine department in palliative care. And we would like to learn from what he has done in Nepal so we can replicate or contextualize that to our context. Thank you.
Okay, thank you very much, Dr. Jennifer, for the warm welcome. It's lovely to be back in Vellore. It's my third visit here, the first one since COVID. And so it's good to be back with friends. Yes, as Dr. Jennifer said, I'm going to talk on experiences from Nepal about integrating palliative care into chronic disease management. Very much. So it's the project I'm going to be talking about is called SUNITA. It's funded by UK aid through EMMS International, which is a UK charity, and in partnership with INF, International Nepal Fellowship. And so what I'm going to do is just outline palliative care as part of universal health coverage, and also the concept of integrated chronic disease management, including palliative care. And then I'll give a background to the SUNITA project, looking at rural health care in Nepal and palliative care development, and also needs assessment research, which we did before the SUNITA project started. And then we'll discuss the rural model that we're developing, and then research and evaluation, and our community involvement. And then there's some of the things which we've learned along the way. So we're going to go back 45 years to the Alma Ata Declaration, which I'm sure you're all familiar with, the concept of health for all by the year 2000. Of course, that was never reached. We still haven't achieved universal health coverage. But the thrust of Alma Ata was that actually universal health coverage could be achieved through primary care specifically. And WHO has not changed its thinking on that. This year, Dr. Tedros, the General Secretary of the WHO, said the world ought to invest in and reorientate health systems towards primary health care as the foundation of universal health coverage. So we're still, that's still the belief that it's through primary care that universal health coverage will be achieved. And here we have the public health strategy for palliative care that the WHO developed back in 2007. And you can see they've taken the strapline health for all and said palliative care for all. How can palliative care be provided? universally. And so they suggested that actually specialists in palliative care will only ever provide just a very small amount of palliative care that's needed, and actually wouldn't be able to have specialists to provide all palliative care. But generalist healthcare professionals should be the ones that provide palliative care. So training the GPs in family doctors in the unit here is a very important part of that. But not just doctors, nurses, mid-level workers. Primary care varies greatly across the world, different models of primary care. And so, but these are generalist health workers, not specialists in palliative care. And also hospital doctors need to know about palliative care, oncologists, cardiologists, respiratory physicians, geriatricians. Everyone needs to be trained in palliative care if they are looking after people with advanced chronic illness. Through lots of advocacy, this was a very big landmark declaration back in 2014 at the World Health Assembly, where countries committed to strengthening or to having palliative care as part of their health systems, particularly in primary care. Palliative care should be integrated into national health policies and provided at the primary healthcare level. Since that time, palliative care has really been part of universal health coverage and is actually mentioned in the Sustainable Development Goal 3.8, achieving universal health coverage by 2030. That involves health promotion, disease prevention, treatment, rehabilitation, and palliative care. And then Astana Declaration, which was 40 years after Alma Ata. Alma Ata had changed its name in the preceding time to Astana. That's why there's the difference there. And again, universal health coverage, including palliative care, as well as the other four parts of the spectrum of universal health coverage. And we have other important documents like NCD management, the Global Action Plan for Non-Communicable Diseases, which was supposed to end in 2020, but has actually been extended to 2030, looking at how non-communicable disease management should happen, again, across the whole prevention and management. So non-communicable disease management clearly requires appropriate guidelines for the management of NCDs, and those are being produced, like the PEN guidelines, a package of essential NCD guidelines for primary care, enabling primary care practitioners to give evidence-based chronic disease management. But actually it also requires something else. It requires really good communication skills so that the patient is, and the patient being seen as the partner in their own management, the key partner in their own management. If you have an acute illness and you go to the doctor, say an infection, you get given antibiotics, you take them for a week and you get better, that's fine. But with chronic disease management, if you've got hypertension, diabetes, you need to take medication for life, and you need to be in control of your own disease management. And so healthcare professionals need to be able to communicate well, be able to answer people's questions, be able to arrange good follow-up and assure the patient of why follow-up is so necessary. But unfortunately, lots of health systems in low middle income countries such as Nepal are still based on an acute model. And health professionals have little skill, both in terms of chronic disease management, knowing the evidence base in terms of treatment, but also having poor skills, the soft skills as they're sometimes called, to develop patient-centered chronic disease management. So why do I say this? Well, when we look at palliative care and it says palliative care is part of chronic disease management, we can get this idea that we should bolt it on, so that palliative care comes into play when a patient is right at the end of life, maybe dying, and that's when they need palliative care. And there's a bit of a problem with that, because if we think of palliative care in that way, it becomes almost the last thing that we're thinking of. Is it more important to be able to prevent people from dying prematurely, or more important to give them good palliative care when they're dying? And obviously health resources are limited. If we take this approach, we can advocate for it by saying, well, it's part of universal health coverage. We know the need globally, about 61 million people every year need palliative care. Palliative care is a human right because of all the suffering that's involved, and it's cost effective. Studies have shown, because actually when palliative care is used effectively, expensive treatment at the end of life particularly is often not embarked on, because people are having a different approach, and therefore it can be cost effective. Whether it's in Africa or in North America, studies have shown palliative care is effective at reducing health costs. And then government should be held accountable for their WHO declaration that they will include palliative care as part of their health services. But we think a much better way of looking at it is palliative care being integrated into chronic disease management. So actually palliative care adds value, not just being a bolt-on, but actually seen as being an integrated part of chronic disease management. And it's because in palliative care, one of the important things that is taught is how to be patient-centered, how to communicate well with patients, how to include continuity. So we believe that this integrated approach is actually even more cost-effective, because we're actually teaching healthcare professionals skills that they need throughout their practice, not just in palliative care. So we came up, Dr. Jennifer worked with us in developing this definition of primary palliative care within the primary healthcare setting for universal health coverage, which acknowledges that primary palliative care is palliative care practiced by primary healthcare workers, and they're the principal providers of integrated healthcare, and they are able to identify people early who need palliative care as they come to see them, and trigger palliative care. As part of integrated and holistic chronic disease management, a family doctor will manage a patient's underlying COPD and give them palliative care. They don't distinguish, oh, this bit's palliative care, this bit's COPD management. It's all part of the same integrated package. This is the way that the generalist thinks. Obviously, they need to be trained in palliative care skills. And then we go on to say that actually the palliative care skills strengthen underlying professional capabilities for primary care. Studies have been shown to say that primary care practitioners often don't have these skills, and actually palliative care can enable people to develop those skills. So that's just a bit of an introduction to what we mean by integrated chronic disease management with palliative care at the primary care level. So we'll just now start talk for a few minutes about Nepal, where I'm working. So as you know, Nepal is there to the north of India, between India and China. It's in the Himalayas, although there's that dark green belt there is the Terai, which is the plain on the Indian border, but the rest of it is mountainous. And it has a population of about 30 million, which I guess is about the same size as Kerala. And it's got a low human development index, average human development index is 0.6, which makes it 143rd in the world. I think India is 132nd at the moment. And it's mostly rural. 83% of the population live in rural areas. And actually, it's moved very recently from being a low income to being a low middle income country. And a lot of people actually in Nepal, a lot of the able-bodied people go abroad to work. So there's a real problem you find in rural areas, particularly. A lot of the communities are mainly women and children and old people. The men have gone off to the Middle East or to other places, India included, to work. So Nepal's very mountainous, with villages perched on the side of the hills. The road structure is poor. It's being built, but it's very difficult to maintain because of landslides. And actually, a lot of people really aren't near a road and have to walk to get their healthcare. So it's quite a challenging area to provide healthcare. But actually, Nepal's had some quite impressive achievements. So life expectancy has doubled between 1960 and now. And one of the reasons for that is the reduction in child and maternal mortality. You see maternal mortality dropping from nearly 800 per 100,000 down to around 200 per 100,000. So there's been a lot of success, and also infection rates have gone down, which means that deaths from non-communicable diseases in Nepal have increased and are projected to continue increasing. So currently it's around 70%, and will go up to nearly 80%, it's predicted, by 2040. So when you do primary palliative care, the first thing you look at is the primary care system. What's the primary care system? What does it consist of, and how does palliative care fit in to this context? So we look at the Nepal system here. So the rural healthcare is based on municipalities, which have between about 30,000, 80,000 people, and they should have one rural hospital, 25 bedded, and staffed by somebody like a general practitioner. In Nepal, MD-GP is the same as the MD family medicine in India. And then there's a series of village health posts and primary care centres, which are staffed by mid-level health workers, so people we call health assistants, who have 2 or 3 years training, and nurses. MBBS doctors are often also work in the primary health centres, but the health posts definitely are staffed by mid-level workers. And then we have provincial and national referral hospitals. Health insurance is being rolled out so that actually people can pay a subscription and then get health insurance up to 1 lakh of healthcare per year for the subscription. And there's a parallel private health system. And often people feel they're going to get better care if they go privately and pay than if they're in the government system, which isn't necessarily true. So there's a huge challenge with cost. Even in the government system, as in India, people have to pay. So as in India, health expenditure is the prime reason for putting people into poverty. And of course, accessing healthcare is difficult because of the terrain. So this is one of the rural hospitals. This is in Besi Sahar. I've been working at this hospital, and it's one of the hospitals where we're doing our project. So palliative care first started in Nepal around 2000, but it was actually mainly based in Kathmandu and in other large centres, not getting out into rural areas. a national association was established, and that national association developed a palliative care strategy along with others, which was adopted by the government in 2017. Basically, the vision of the strategy is that palliative care for all people should get palliative care wherever they live, not far from where they live. So this is it being handed over to the government 2017, and the minister later signed it. So in the strategy, it says that rural hospitals should have one MDGP and nurse to lead palliative care and to receive training in it. But they should also be supporting the staff in the health posts and the primary care centres. And then everyone else should have training as part of their, well, the vision is that eventually it'll be part of their undergraduate and postgraduate training. Everyone should be aware of palliative care. And then the same in health posts and primary care centres, everyone should have basic training. There's this group of women, female community health volunteers, I think are similar to ASHA workers in India. And the strategy identifies these people as actually being a link between the families in the rural areas and the health service. And they should also receive training. And the strategy also talks about the community, as you saw in that triangle that I showed of the WHO strategy. Specialists at the top, generalists, palliative care, generalist health workers providing palliative care. But then at the bottom, it was the community. The community should be where the communities where most care is provided. Obviously, people in from families and in communities. So the Nepal strategy acknowledges awareness building needed at various levels in the community. So that's basically the strategy and the Nepal health system. So in INF, we've been doing work in Nepal. Our project started in 2022, but we'd been doing needs assessment work for around 8 years before that time. And so I'm going to talk about some of the needs assessment things that we did. So first of all, we did some modelling to actually understand the number of people actually needing palliative care in Nepal and the type of illnesses that they had. Now, the data which we modelled is actually not very robust because there aren't surveys that actually look at how many people have got COPD, how many people having strokes and heart failure. But this was the global burden of disease data from WHO. So it shows actually that cancer really is only responsible for a small amount of the palliative care need. Most palliative care need is from other non-cancer illnesses, particularly cardiovascular and COPD. So we did a survey at Tansen Mission Hospital that some of you might be aware of. It's 166 bed mission hospital and serves districts in West Nepal, and also people come up from India to receive care there. And now it's able to provide healthcare under the insurance scheme. So actually, insurance, you don't have to go to a government hospital. You can go to a hospital that's registered. That might be, it has to be not for profit, but another community hospital. So Tansen has been able to be part of that insurance scheme. So we surveyed all the admissions over 5 days, anyone admitted with non-communicable disease, and also included HIV. And then we use this tool called the Supportive and Palliative Care Indicators tool to identify patients, which I'll mention a bit later. And we found that about 30%, 28% of the admissions were people with NCDs. And actually that is the same as other studies that have been done in Nepal looking at admissions. Around a third of admissions are from NCDs in rural hospitals. But of the admissions, 10% of people needed palliative care, so 23 out of 234. And actually, when I was working in Bessie Sahar Hospital, which I showed you, we were finding the same thing. Around 10% of admissions in the rural hospital had palliative care needs. And by far the most common was COPD. So the actual number of people with COPD is in blue, and the number of palliative care needs is in red. So you can see that actually 2/3, 3/4 of the people with COPD had palliative care needs because they present late. They're coming with acute exacerbations. They're affected in between exacerbations with breathlessness or problems with walking and things like that because of their breathlessness. And so you can see the other things there: heart failure, cancer. Only 2 patients with cancer at that time. We found a number of people needing palliative care. Part of the reason for doing this survey was we were introducing a palliative care nurse into Tansen Hospital, and just to understand what she would be facing. So actually, she became very much an expert in managing COPD, as you would expect. Then we did a rural house-to-house survey where we were looking at 100 houses in 5 different villages, so 500 houses altogether. And actually, we got funding to do this result after the 2015 earthquake, which we were looking at places affected by the earthquake. But it was quite a rough and ready project, non-random sampling and remote areas, but areas that our research team could actually access. So we went house to house asking people if there was somebody there with either chronic illness, frail and old, or with a severe disability, and then delivering a questionnaire. So we found out of the 2,000 people in that population, 85 had palliative care needs, just over 4%. Interestingly, actually, what we found was that actually a lot of people haven't really had a diagnosis either. You're looking at them and thinking, well, they've probably got COPD, but no one's actually diagnosed it, and it could be something else. And so that was quite an eye-opener. But as you can see, increasing numbers of elderly people, obviously in Nepal, so frail elderly, and dementia as well is becoming quite common. So this is one of our researchers doing an interview, and people were living in these temporary structures after the earthquake. As part of that project, we also started to train the rural health post workers, we found when we trained them that actually they really were very keen to receive training because they recognized that there are people in their communities with palliative care needs. The thing that they really valued was the communication skills training. They'd not really received that before, and they found that really helpful when we went to evaluate the training the next year. That was the thing that was picked out as being the most important part of the training. Problems with the slides there. Found was that actually they struggled with English texts. In Nepal, Nepali is the national language, and doctors and nurses are trained in English, but actually the mid-level workers are trained in Nepali, and they have some English texts, but also mainly Nepali texts. So we translated a thing called the Palliative Care Toolkit, which is just a basic manual for palliative care. We translated into Nepali over the next couple of years over the COVID period. There we go. That's the Palliative Care Toolkit. And I talked about the SPICT, the Supportive and Palliative Care Indicator tool for identifying people with palliative care needs. And as a result of using it earlier in our needs assessment work, we actually realized that the tool which was developed to be used in the UK was actually not completely suitable for a low-income setting. So over the next few years, we developed this new tool for low-income settings, with, working with people in India, Nepal, and sub-Saharan Africa. And we translated this toolkit into Nepali, this SPICT into Nepali as well, which is actually in the toolkit. So this led us up to the start of our Sunita project. It's a 3-year project between April 2022 and March 25. And it's to develop a rural model of primary palliative care for Nepal. And it builds on the government health services. So we're working with the, don't know. Anyway, I'll carry on. So it's a 3-year project from April 2022 to March 2025. And it's basically to implement the national strategy. You saw how the national strategy just describes what's going on in how palliative care should be provided. Of course, the strategy is very high level, doesn't say how you do it. So this is to actually develop that model. And so we're taking a health system strengthening approach, working in 5 different areas. And any family physicians here will know about the community-orientated primary healthcare approach. This is what we're using, where we actually work not just with the healthcare providers, but also the communities and sort of multi-sectorally. So this is our palliative care unit in Pokhara, with the Annapurna range there in the background. And that opened in 2021. And the idea of this unit is to do research and training as well as providing clinical care. And it's from this unit that we're delivering the project. And these are the districts that we're working in. 3 of them are rural districts, and 2 of them are on the Terai, the plain. We've yet to start working with those districts yet. And this is the model basically. So the healthcare there on the left-hand side in red, the communities in blue, and then the FCHVs who straddle the healthcare system and the community there in purple in the middle. Now, just to mention, as I say, they are like ASHA workers, I think. This next slide can tell you whether they are. So they're community members, they have basic education, they're responsible for a selected number of homes in their area, and they receive basic training in health promotion, particularly maternal and child health. And they work with mothers groups, particularly in the community, and then link in with the health posts, particularly for monthly training and management sessions. And as we've seen, they're identified as being important for palliative care within the national strategy. And when we went to talk to them to start with about palliative care and what they thought, they were really keen. They said, we get people coming to say to us, what do we do? But we've got absolutely no idea. But we're looked upon as being the people who know about health. So we're who people come to. So they're very keen to learn. So this is the training that we do. So we train, so this one MDGP, it's not always an MDGP, sometimes it's internal medicine or a senior medical officer, but whoever's nominated to leading the palliative care, we train them for 10 days, partly in Pokhara at our centre, where they come onto the wards, go to the community, as well as having lectures and group discussions. And then we take them to a rural hospital, and we actually train them on the wards, assessing patients who've been admitted, because that's where they're going to be working. So they don't need to learn in a teaching setting, in a palliative care setting. They need to learn in the rural setting as well. And we train 2 nurses for 6 weeks, really to undergo palliative care, to make palliative care assessments. But also these nurses who we train are also involved in doing the community education, which I'll come on to in just a minute. Then we do 2-day training using our palliative care toolkit, which we've translated into Nepali, and the SPICT LIS for identifying patients. We train hospital and health post staff together because we want them to form a network. That they tend not to work very closely together and not even know each other, but we think they need to be able to work together with palliative care patients as patients move between home and hospital. We introduce palliative care and then we train them with case studies to use the SPICT. It's very straightforward, and these are type of cases that they're used to seeing. We do a lot of communication skills training, so a quarter of the training is communication skills. And then we train them how to use the toolkit to actually be able to do symptom management. So if you get somebody coming to you with breathlessness and we give them a case scenario, go to page so-and-so in the toolkit. Okay, what does it say here? How might you help them? What sort of things might you do? And you go through several cases. So what we're doing is we're trying to give them a resource that they can use. Unfortunately, we can't do more than 2-day training because that's all the time that they can be released for. But so we want them to teach them the skills for approaching palliative care. And then we do a few small talks. Particularly, we talk to them about preventing pressure sores because that's a huge problem in Nepal. This is training going on. Raj Kumar is an MDGP who's training in palliative care, who's working with us, who's teaching about the SPICT. And here they are using the toolkit together to actually look at how will they manage cases. And then we go on after that 2-day training to use ECHO. Project ECHO is a distance learning system. It's used internationally. And actually in India and in Nepal, ECHO is provided free of charge. You can actually get training and use it. So basically what it is it's Zoom, but with other facilities as well, a website where you can put training material on, where you send invitations to the training and everything, and which runs also the training. So everyone clicks into the website to get onto Zoom. And so we've set up ourselves at Green Pastures Hospital as an ECHO hub, and we do training with the rural teams. It's not quite got off the ground yet. We're also doing it with a group called Gurkha Welfare Trust that look after people who've been in the British Army, and we're also training them in palliative care. So we're testing it out with them at the moment before we go on to the rural hospitals for technical reasons. And then our doctor and the nurses are the ones that actually do the palliative care in the rural hospital. And basically, these are the 3 core skills for primary palliative care. First, identification, next, a holistic assessment, and then basically care planning and coordination. So patients are admitted, they're identified with the SPICT LIS on the ward round. This is one of the hospitals we're working at. You can see the SPICT laminated and hanging on the notes trolley to encourage them to use this when they're going around. After the doctors identify with the nurses, the doctor's role is to consider best available treatment. Now, I'm sure you're all aware that palliative care isn't about helping people to die. It's about giving people holistic care who've got advanced illness. And an important part of palliative care is making sure someone has appropriate treatment. So if you've got somebody with COPD, you need to make sure their inhalers are optimized, they have the correct dose of steroids, they get correct advice for exercise and that sort of thing. So the doctor, we really stress this, best available treatment is what is needed. Then the nurses go and make a holistic assessment and help the patient to form a problem list. So this is one of our, well, this is from a number of years ago, but one of our nurses that we trained a while ago, doing a holistic assessment with patients and their carers. And we have this simple record form that they actually complete, which has got a case history, about symptoms, what the patient knows about their illness, and also to asking them about their mental state, asking them about whether they feel low, whether they feel anxious or depressed, talking about their families, who's in the family, who's looking after them, what they're able to do in terms of function and their social situation, and then helping the patient to form a problem list. What's most important to you? What's the most important thing for us to address with you? And then once the nurses have done the assessment, they can then go back to the doctor, and together they can discuss what the best plan is for the care. And then, of course, this needs to be completed. But the nurses also work in other areas of chronic disease management, and actually I found this on Facebook. Two of our nurses at one of our rural hospitals doing blood pressure and blood sugar measurements. I just hope they checked his blood sugar before they pricked his finger. The other thing that actually we're doing in the project is looking at medicine availability. Now, Nepal is very fortunate in that morphine is available in Nepal. It's manufactured in Nepal, and any doctor can prescribe it. It's not got very stringent rules about prescribing, but it doesn't get into rural areas. So we've employed a pharmacist to look at that, to look at how we can get palliative care medicine available. And he actually, working with us, realized that actually there are some challenges with the essential medicines list, and has been rewriting a new one, and we're in the process of developing a palliative care formulary for Nepal, not just for our project, with other healthcare workers, other palliative care professionals. And so we come on to the community finally. We train FCHVs for 2 days, and to identify people, and also to give simple support and advice to the families, awareness building in the communities. And again, the FCHVs can introduce us to the mothers groups and work with us in raising awareness. And then finally, we were also working with schools. We find schools are really important places, centres of the community, and making children aware of chronic illness and the way they can be involved in caring as well. We're doing exploratory research, building on the research we did previously, the house-to-house research, but doing it in a much more robust way. And we're just starting to see some of the results emerging from that. We finished the field work, but a big part of it was doing qualitative case studies, looking at health-seeking behaviour, caring practices, because we want to build on what people do already and do what's appropriate for them. When we did a literature review, we found that nothing had been written, published about these things. And now we're just moving on to evaluatory research, which we're taking an improvement science approach, plan, do, study, act type approach, and also collecting stories about how things have changed for patients and carers. Community engagement has been really important, meeting with community leaders, partly to get permission to work in the areas, but partly to understand what they see as being the important things. So it's interesting is that sometimes what the community wants isn't quite what the funder's expecting us to give. So we have to negotiate with them and try and fit the project to what their needs are. Like, we're talking about availability of getting medicines in general. So actually, how do we help them think that through? And then doing feedback meetings with them, discussing the results emerging from the research and getting their views on what we're finding, and helping us to interpret what we're learning. This is a community meeting going on, and this is a little bit more grand. This is our 6-monthly task force meeting. We meet with a group in Kathmandu, experts and government officials, and chaired by someone from the Ministry of Health, to discuss the model, what we're finding, and to get feedback and helping us to direct, to make sure that what we're doing is actually appropriate. Because what we want is, after the 3 years, for the government to feel they have a system which they can then roll out to other areas. It's not very expensive, not very resource intensive, because we're not introducing new people. We're actually training who's already there. So what have we learned? Well, the first thing is actually that the strategy has been so important to actually help us to see where we're going and to ensure that we retain our focus of what we're doing. And also, and I realize this much more now than I did before, I think, is engaging stakeholders at every level, from the government to the districts to the municipalities, to the local communities. The needs assessment was really helpful in terms of developing at the early stages of our research. We didn't know we were going to get the funding for this when we did the needs assessment, but I think getting the funding was actually based a lot on the needs assessment we'd already done, and also good knowledge of the primary care system. So say you start with the primary care system in primary palliative care and build palliative care into it, not tell them what you think they should be doing without knowing what their system is. And then we built in funding for exploratory research, because we knew we would have to do a lot more to really understand what was going on, so that we could understand the local resources and build on them. But there have been many challenges. COVID-19, we applied for the funding before COVID, or just before COVID, and then it caused difficulty in all the preparation work which we were going to do. Governments change, regulations change, and so we had to actually adjust to that very early on and change our model. Our main partner hospital, after 3 months, was no longer available, and we had to adjust what we were doing. We had to look for solutions to that. So now we're working with 3 different hospitals, where we were just working with one. So that's okay. It's meant us needing to redesign our approach a bit. But you know, I think we're on course. And then I mentioned about the funders' ideas, maybe not quite the same as what we're finding, and we have to be flexible, and that's not always straightforward. And so we need to accept what's possible, rather than maybe be too concerned that we're not completely meeting our previous aims, but try and stay on track as much as possible. So just coming to the end, yesterday was International Universal Health Coverage Day, which we celebrated at the low-cost unit there, which was great. And the strapline for this year is Health for All, Time for Action. And I think that, you know, we really need to be working towards making primary palliative care work. And I was so encouraged to work with your family physician colleagues over the last couple of days, looking at how primary palliative care can be developed for Vellore, for the poor in Vellore. And so, you know, that model can actually influence other people as well, and give people other outside ideas of how things can develop. So really exciting things going on here. So thank you very much for the opportunity to talk to you, and do come and visit us in Nepal.
Dr. Munday, for that for inspiring us with the work you're doing in Nepal at the community level, involving the community, the healthcare workers, schools, and everything possible to integrate palliative care, a crucial component in management, chronic disease management. I would like you all to comment or ask any questions if you have to Dr. Dan Munday. Those who have joined online as well, if you have any questions, you can either type in or unmute and speak. Any comments? I can see some from here. Okay, if you have something to ask. Okay, thank you very much. If there are no comments or questions, we really want to take this opportunity to thank you again, Dr. Dan Munday, and thank you all for coming.